My name is Lacey Pavlovsky. I'm an infection preventionist with Nebraska ICAP, and I'm also the Nebraska DHHS Healthcare Associated Infections and Antimicrobial Resistance Infection Preventionist because you need a really long title. It's really fun. So I'm here today to talk about how to interpret microbiology results as an infection preventionist. And I wish this talk would have been available and somebody would have guided me through this when I started in infection prevention over 10 years ago, because I really like in nursing school, they don't teach you this. They just say, hey, look at this result. And you're like, I don't even know what this means. Like, I don't know how to say in these organism names. They don't teach you those things in school. So that was one of the things of feedback that we got when we were going through the summit is they're like, we'd really like somebody to review, like, how do we know if something's resistant? How do I know what I'm supposed to do with these lab results? So that's the goal of my talk today. Hold on here. There we go. Okay. I don't have any disclosures. Objectives, like I said, are to equip infection preventionists with the knowledge to accurately interpret microbiology results and then like know what to do with them. Is it showing you that someone's colonized with an organism? Is it an active infection? How do I know? And also give you practical examples, and I have a lot of examples in these slides, so of what these microbiology results look like and how to interpret them, and then like what do I do once I see this results. And also highlight like the different crucial factors that could influence the like how you interpret the results. There are some different things that you may not know or think about with certain organisms that are just good to have in the back of your mind, and I'll give you some tips on things to keep in mind. So the very first thing I would ever recommend if you get a chance is if you have a chance to go into a microbiology lab, particularly the one that your facility uses, to watch them do something, do it. Spend a day in there. That, like, if you ever get, like, go and watch them from how they get the sample all the way through how they process it and result the results, because that'll give you such good context as to what you're actually seeing and help you through that process. So the main three steps, and this is really simplified, and Dr. Iwan's in here, and he's probably like, Lacey, this is so simple, but this is a simple way to think about how the microbiology lab process works. Is they're looking to isolate an organism from a clinical sample, identify an organism, so tell you what it is, and then if it's an organism that you can do susceptibility testing on it to see what antimicrobials they're resistant to or not resistant to, so you can treat the patient appropriately. Jenna, our pharmacist, found this lovely example of how the microbiology process works within like a timeline. I think this is a wonderful diagram to show what they actually do in the lab. So first you have a patient who is unwell for some reason, and a provider orders a lab and says, hey, you need to collect the sample, which if you're a nurse or, work as a clinician before, collecting those samples sometimes are not very fun, but say you have to get like a urine sample, blood sample, something else. Anyway, you collect it, you send it to the lab and they start processing it. Then they do some sort of usually bacterial culture, or there's other things they're looking for, like a fungal culture, something like that. Usually lately, there's a lot of automated processes that do these processes for you that provide susceptibility testing. There's some other tests called, if you've ever heard like a MALDI-TOF, that's, I know a lot of their favorite machines. It's a really big machine. I don't really know how it works, but it's really cool. And it looks really impressive when you see them. And then they do some sort of additional susceptibility testing, and then you get your final report. It can take a while, up to 96 hours. And if it's for something that's like you're testing a patient for tuberculosis, it can take weeks. Fungal cultures, if you're testing for something that's like you're looking for like Candida auris, so another fungal infection, that can take a week. It takes a long time. So like a lot of times, they'll get started on antibiotics, empirically, like Dr. Ashraf was talking about, and then you don't get the results until like 96 hours or longer later. And then you're like, oh, wow, that was not the right treatment or something like that. That's just something to think about. There's also a lot of new rapid diagnostic tests, which I'm sure that you guys have heard of these. Like there's different PCRs are really popular. That's something that is pretty quick. There's also like carbapenemase testing that you can get back a test pretty quick to see if an organism's a carbapenemase, but those are just some terms to be familiar with. So the goal for the lab is they are trying to identify either bacteria, fungi, viruses, or some other fun things. I don't know if I've ever seen like a protozoa, but anyway, that's what APIC said that people try to identify in the lab. I don't know how often they find it, but those other things that they're trying to identify. So here is a lovely picture of like what a bacterial cell looks like. I'm not going to go into that because I do not know. I wouldn't be able to tell you how that started. I do not know bacterial cells that well, but this is like what a what they look like. This is what a little plate can look like if something's growing. Dr. Iwan, what is this one? Do you know? By looking at it, can you tell what that is that's growing on the plate? Is that a staff? Cool. See, we got Dr. Iwan in here. He's gonna tell us, and or a virus or something like that. They're trying to find different things. So you're not going to find a virus on a plate, but there's just different pictures of what we're trying to identify. So that was the other picture. That was this picture. This is another helpful chart that's on page 17 that I wanted to point out in your workbook. I have some marks and notes in here that you guys can kind of look at your notebook as we're going through. That can kind of tell you it's a good flow chart. I think Dr. Tehran's going to talk about it more in his presentation as well, but it can tell you like what different anaerobic organisms are. Aerobic, if you ever wanted to have like a quick cheat sheet, this is a cool one to have. And there's also several different types of cultures. You can pretty much culture almost anything in the human body. I think, I mean, you can culture bone. The most common things that you culture that you're going to see in the long-term care setting are probably blood, a respiratory culture, urine, wound cultures, or poop. We culture poop a lot. So those are different things. And these are kind of what the different supplies look like. Here's some common methods and words that you're going to hear. I just wanted to put them out there so you're familiar with them if you hear them when you're out in the wild. But sometimes, they just look at different, they put stuff on a plate and look on a microscope and can tell what something is. They do things called a gram stain where they put like a stain on top of the organism, and they're really cool. It's really cool to look at those if you're ever in the lab and you can be like, oh, hey, and they'll show you all that stuff. There's an acid fast stain, which I'm sure you've heard of. Acid fast is something that's related to tuberculosis testing and other organisms like that. There's the streak plate. That's kind of cool when you see that under a microscope. I don't really know what they're doing, but it looks really cool. And PCR testing, which is one of your see, you guys see it? Like I don't know how it'll work, but I just know like you're going to hear that when you go through the lab, and it's just stuff to be like, oh, they're talking about microbiology testing when they talk about these things. So on page 7 of your workbook, this is what Miss urine culture is going to look like. Hint, hint. I just so you guys have something to look at. It's important when we're looking at these different bacteria to understand like what it means when you're looking at a test result and knowing if something is resistant to antibiotics or not. It's really important to know that your patient and your resident is receiving the right treatment. So if you get back a lab result and something says resistant and that's what they've been on for a week, they're probably not getting better. They could have gone to the hospital. Their symptoms could have gotten worse. We want to make sure that we get them switched to the right treatment. But this also impacts your infection control and what you're going to do for like contact precautions. If you would need to do colonization screening, if you had a certain organism result like Candida auris. I mean, there's several different things you have to think about, like what you're going to clean with. There's some organisms that are more resistant than others to different disinfectants. You might have to transition or buy a new disinfectant based on the results that you receive. So here's a chart that I think is helpful that I know you guys have seen these when you're looking at antibiotic susceptibility testing. You always it's like the antibiotic in the first column, and then it says MIC and what the interpretation is. So if something has an S next to it, that means that it is sensitive or susceptible, and it implies that the organism was inhibited when they put it on the little test. and that the normal dose of that drug that they usually use will kill that organism. Intermediate implies that it was only it only like would kill the organism if the maximum amount of that drug you can use was used. So maybe like if something's intermediate, that may not be the best choice for a clinician to order that. If it's resistant, that means that the organism is resistant to the usually achievable serum level of that drug. So MIC stands for the minimum inhibitory concentration. So again, that's the measure of the drug, and you're going to see that all over the place. And who sets these rules? Well, there's a group of people called the U.S. Clinical and Lab Safety Institute. And I have more about that on the next slide, but they are a group of different people who decide this and review it frequently as organisms evolve. They update it all the time. And again, here's a graph that I stole from one of our infectious disease physicians, Dr. Hankins, from one of his presentations. But susceptible means that there's a high likelihood of therapeutic success for that drug to be used. Intermediate or indeterminate, uncertain, maybe not the best choice, and resistant means there's likely going to be therapeutic failure. So CLSI, like I said, they're the ones who do the develop these standards for susceptibility testing. The standards are usually updated annually, and it's a group of people, like a lot of different parties. There's physicians, microbiologists, pharmacists, and some people from the pharmaceutical industry sit on this board. And here's an example that I thought I just pulled an example of something that they updated recently in March of 2025. This was aminoglycoside mic breakpoints that they updated. And this is something that I know pharmacists, Jenna is probably way better at talking about this than me. She's the one who helped me find this stuff, but they would review this and make sure that they're getting, that they were familiar with these standards. But just something to know that if you've ever heard that, that's what that group does. There's many different methods to do antibiotic susceptibility testing in the lab. There's manual methods. The ones that are more common would be like your automated methods. I know a lot of facilities use what's called a Vitek 2 machine. There's a Phoenix, a Microscan. Several different companies do different types, but if you've heard those terms, those are the different types of machines that do susceptibility testing. And they can also identify different resistance genes with these different machines that they use. And I thought this was a nice table to kind of tell you, if you see this result, this is something you could save, that means that it usually there's an indication that they're resistant to certain antibiotics. So if you see like a MEK-A gene or a MEK-A/C gene, those genes usually mean that in your test result that antibiotic is resistant to methicillin or other beta-lactam antibiotics. And usually that has to do with a staph organism most commonly, but I'm sure that could be identified in other lab results. But vancomycin, we'll say Van AB, they usually match. Sometimes they don't, it's like, oh, vancomycin, those go together. But then you get like CTM-M, and that goes with ESBLs, and that doesn't really make sense at all in my brain because I did not make that rule. I didn't make up that gene name, but that's just that's why we have a little cheat sheet that can help us identify that. The ones that I personally am most familiar with, based on what I do for a living, are the carbapenemase genes that you'll see. The most common ones are listed on the bottom of the slide. They indicate that there's resistance to carbapenems, such as ertapenem, meropenem, or imipenem. And that would be your KPC gene. That's the most common in Nebraska, like you heard Dr. Ashroff talk about earlier today. That's where we've seen almost a quadruple increase over the last year of the number of KPC cases that we've seen. IMP is not common. We've only identified a few of those in Nebraska. I don't know I think maybe once we've identified a VIM. That's not very common in the United States. NDM is probably our second most common carbapenemase gene, and followed by OXA. And these are most often associated with your Enterobacterales. So you're going to see them with like E. coli or Klebsiella, Citrobacter, the main ones that Morganella, there's several of them. Or Pseudomonas or Acetobacter can also have a carbapenemase gene. You also need to know when somebody is having like an active infection versus colonization. That also helps you make decisions when it comes to infection control, mitigation measures. Like if somebody has an active infection of something, you're more likely to want to use contact precautions in the long-term care setting because they have an active infection that they can easily spread to others. If they're just colonized with an organism, depending on what the organism is, you can probably just do enhanced barrier precautions and the resident can still go, to activities and meals and those kinds of things. So that's something to think about when you're looking at these labs and you're like, oh, how do I know? Are they actively infected or colonized? So when someone is actively infected, they're causing current symptoms of a disease. So say they have an active VRE infection in a wound that you can't contain the drainage, and it's draining and you're having to change the dressing every hour and they should probably be in contact precautions. That tells you that they have an active infection that they're currently treating and they should probably be, until they're improved, you could spread that to other people. When someone's colonized, they're not going to be able to, they're not actively infected, but they can still spread. It can, like, for an example, Candida auris can live on your skin and you still can spread it if with like high contact to somebody, which is why we use enhanced barrier precautions when you have high contact care, but they're really unlikely to spread it in a community setting or like an activity setting like this when they're sitting at a dining room table. They're not having intimate, close contact with somebody where it's like spread on their skin. For an active infection, usually treatment is done on a case-by-case basis. And for colonization, you usually don't need to treat them. They're colonized. They're just going to be like that probably forever. So when someone has MRSA in their nose, they're always going to have MRSA in their nose. That just is what it is. You can decolonize them, but they're likely to become recolonized. And there's a lot of different methods for that. That's not what this talk is about. But yeah, active infections can spread easily. So can colonization, but active is more likely to be able to spread from person to person. And usually if you're to identify an active infection, you're going to see that more on a clinical culture where for a colonization, it'd be more of a screening culture and you're going to have it called a screening culture. Not always, but usually you'll be doing some sort of screening culture. So for like a carbapenemase producing organism, for them to be colonized, you do a rectal swab, which patients love that, but that's the screening patient, like you would do a rectal swab. Or for Candida auris, for colonization screening, you swab their armpit and their groin because that's where yeast likes to live. So that's where you swab. So anyway, there's different types of screening for that. People love that one too. I just wanted to throw this slide in here. Multi-drug resistant organism tiers for Nebraska. I'm sure, who's seen this before? A lot of people. Okay, this is a good one to benchmark. It has good recommendations on it. We're going to look at several different of these organisms. I have examples of them today, but the ones that we mostly see or most concerned about in Nebraska would be tier 2 organisms. Those are the ones I really want you to know how to identify in a lab report. Those are your carbapenemase producing organisms and Candida auris, or if you had some organism that was pan resistant to all antibiotics on a susceptibility panel, that would also be concerning. And when you'd be like, yeah, we need to treat them as a tier 2 organism. Your tier 3s would be your ESBLs, your CREs that are not carbapenemase producers, or carbapenem resistant Pseudomonas. You would also want to use precautions for those. Tier 4s are more endemic and you wouldn't necessarily have to do contact precautions unless they're having like a raging active infection, like I said, like a wound or something that you're having difficulty containing. You would do contact precautions per your risk assessment. And you could consider doing those for enhanced barrier precautions if that's your policy and procedure, but I know a lot of people are choosing not to do enhanced barrier for MRSA and VRE, and that would be okay. We would usually say to do enhanced barrier for a tier 3 and above. So here's the fun part. Here's the examples. And I apologize in advance for all the black. These are real lab examples that I took out of different sources that I have and had other people pull for me so you guys can kind of see what these results look like in real life. So this is the first example of how you could maybe determine if somebody was colonized with MRSA versus having an active infection. Usually a MRSA infection is done for like a nasal swab to determine if somebody was colonized with MRSA. So up their nose. And so if you see a MRSA PCR in their nose, that's usually they're checking to see if someone is colonized with MRSA. Most of the time, I wouldn't say that's done in the long-term care setting, but something to be familiar with. They do it a lot of times. A lot of facilities have a process to do that for like your pre-op patients if someone's going for surgery, so they know what kind of like pre-op antibiotics to give them. Usually if somebody has more of an active infection, you'll actually see a like a whole culture report where it has, the susceptibility testing that might help you, like hint to you that that's more of an active infection depending on the patient's symptoms. It could be colonization too, but again, you need to look at the whole clinical picture, but that would be more likely to detect like an active infection. Here is what a carbapenemase producing CRE culture could look like. On the first example, you can see that it says carbapenemase detected on the top. Like that's a big one. Then it has like a star. If anything ever has a star by it, make sure you're like, yeah, that's important. We want to know that's important. And if they say results reported to the state health department, that's also probably important. That means they called me about it. And that means I probably called you already. But anyway, that's something to look at for sure. The other thing you want to look at when you're looking for CRE, like I said earlier, is you want to look for resistance to the carbapenems. So you can see ernapenem. At one point in time, I had these highlighted, but apparently that didn't happen. But ernapenem is resistant, imipenem is resistant, and meropenem resistant. Those are like your big ones that you're like, ooh, that's a CRE. Like I need to pay attention to that. In this, particularly if it says carbapenemase, like that's something you want to look for. There's also, this is an example of what a carbapenemase screening test result might look like. This is what, like I said, the rectal swab that everybody loves. I included what a negative and a positive test would look for, because sometimes it's important to know like what a negative test looks like. So you can see on the top example, not detected, the the bottom sample detected, and it'll tell you the different genes, if it detected a gene or not. But those are just some examples of that. Any questions on those? No. This is also an example of a different look of something that shows you that it is a carbapenemase producing organism. This result shows, like it says, microorganism agent. It says it could be a Klebsiella oxytoca. And it says this isolate is positive for a KPC carbapenemase. And they always put it in like red. And they tell you an infectious disease consult is recommended. That should get your ears triggered. Like, oh, if they say ID needs consulted, I should pay attention to that as an infection preventionist, because that means there's something there and they probably need to adjust antibiotic therapy and put this patient in isolation. Usually a good call. So that's another example of what that looks like. Here's an example of Candida auris, what test results look like for that. We don't have a ton of this, like Dr. Ashraf said in our talk earlier, so I thought it'd be good to show some examples of that. Typically, it'll say Candida auris colonization culture. So it'll flat out tell you that they're checking for colonization. That patient probably doesn't have an active infection, but we're checking for colonization. And it'll tell you the source and what the result is. There's also some PCR tests that can be done that this could detect colonization or active infection, depending on what you're looking for. But here's an example of what a positive and a negative test look like. Here is a Candida auris, like actual culture. They're kind of hard to read sometimes, but if you look down in the very bottom corner here, it says this was a wound of some type. So it'll tell you the source, where the body site was, where Candida auris isolated. So sometimes you have to look on the last line to find like what you're looking for, but this would be an example of what that would look like. You'd probably need to do further investigation to see if the patient has active symptoms and what's going on. But then there's another example of where sometimes you find more than one thing in there. There's more than one type of yeast or something. So this patient had more than one, but they, moderate Candida auris isolated with rare exception. Like this was a bronchial culture. So they're not thought to cause pulmonary infections, more likely to be like a colonization or a contamination. But you would also want to look, to see what kind of symptoms they were having and look more in to see what kind of symptoms the patients were having and why they collected the culture in the first place. As a lot of people have said, and they said it in the diagnostic stewardship talk, there's these new multiplex nucleic acid tests that are coming out where they have a whole panel of things. And you're like, why? There's a lot of things on here. So this is a really good guidance document that I found on the Nebraska Medicine website that tells you, it goes over like the pneumonia panel. And it had this lovely table on it of all the different organisms this panel can test for and all the different resistant genes it can test for. And this is an example of what a positive one of those panels looks like. And it tells you that the patient had Klebsiella oxytoca and had a KPC gene identified on the same panel. I would like to make the caveat that just because both of these are resulted on the same thing, it's not 100% saying that the Klebsiella oxytoca is what is the KPC producer. Sometimes these are super, super, super sensitive tests and they can detect colonization with a KPC. That doesn't mean that that organism that they identified is necessarily the culprit. Like they're not the one. It may not be the Klebsiella oxytoca that is the that's causing the carbapenemase to be picked up. But that's usually, they always try to run these after they get the initial positive test result. The lab will then run this for culture to identify the organism and see what organism is causing the carbapenemase production. It doesn't always work. Sometimes you pick up something on a panel and we never know what organism caused it, but just something I wanted to make sure you guys were aware of. Here's some other examples I'm sure that you guys have seen before, but things that are important for a long-term care setting is what like a COVID influenza PCR panel could look like. Now they actually like offer RSV on the panels too sometimes. So you'll see, that they collect it with a nasopharyngeal swab, COVID not detected, and flu A and B not detected. And usually it's laid up in some sort of like a line, but not always. They don't always look very pretty. And then another thing that I wanted to bring up is looking for like group A strep testing. Here's an example of both a positive and a negative sample. And it's not really like, sometimes it's not flashy. You know what I mean? Like you see that it says positive, it's just black and it doesn't really like stand out to you. I like it when labs make it stand out and bold and make it really obvious, but they don't always. So that's something that just to keep in mind. And group A strep is something you'd want to isolate your residents for 24 hours until they're on antibiotic therapy for 24 hours, effective antibiotic therapy. So just something to keep in mind. Here's an example of what a blood culture result looks like. I always think that there's several different ways you might see this. So again, it says culture result. This was the gram stain. They do the gram stain first. We talked about that being a method that they use in the lab. And then they, formalize the report later, but it can take a long time to get to that susceptibility report. But this is a MRSA example of what a MRSA blood test would look like. And you would think that, I don't know if it took me a while to realize this when I first got into infection control. I always was looking for it to say methicillin resistant, and it doesn't. That's not the antibiotic they're going to pick out on the lab. It's oxacillin. So if something is resistant to oxacillin is what you're looking for when it has to do with MRSA. No one ever told me that, but so I just like, I don't know. Yeah, that they don't ever result methicillin on a culture report. I don't think I've ever seen methicillin prescribed. I don't know, but it's like it isn't used anymore, but they do oxacillin. So here's an example of a negative blood culture. I was trying to get negative and positive. Usually blood cultures they let grow for 5 days is the typical, unless they're looking for a fungal culture or something like that. But a typical bacterial blood culture, they'll finalize within 5 days. Here's some other different like urine culture examples of things that you'll see. Like in this top picture, it was a urine culture that did grow something, but it was considered normal genital flora. So they just wrote normal genital flora isolated, which probably means does not need to be treated because it's something that's normally there all the time. And you can just move on from that lab result. And a lot of, different labs have an automatic trigger that when certain like urinalysis results come back, that they're going to automatically send something for culture. Not always though. So you need to know what your lab does and you need to know what the protocol is. So just something I wanted to point out, that you need to know if your lab, if you send a UA, will they automatically reflex to a culture or will they have to have a separate order for that? Kind of, it just depends on your lab and your protocol, but something I wanted to point out. Here's an example of what an abnormal urine culture will look like. They will result in like a CFU per milliliter. So if you're familiar with like NHSN criteria, usually they say over like you have to have a urine culture that's over 100,000 colony forming units. This one would not meet NHSN criteria for a CODI. I know you guys are not in and you don't do that for your, usually don't do that for your surveillance, but acute care does. But it's just something to look at, the colony forming units. A higher number usually indicates that there was more bacteria in the whatever they were looking at. There's more there. And here's an example too of a completely sensitive E. coli result. So there's really nothing too exciting about that. You'd be like, oh, look at all those S's. That's great. That person can be, I have no idea what you would treat them with. Alex, what would you treat them with on a totally susceptible? What would be a good one? We have a farm. Okay, so then I'd be like, here you go, have fun. Here you go, Alex. But totally, there's no infection control thing for me. I be like, okay, let's treat that and we can move on. So here is some sputum culture results that I thought they look totally different depending on what your lab looks like and how they send it. There's totally different examples. So this one's really little. Sorry, guys, that's hard to see. But this one just has a line about what the microorganism was, that it was positive for KPC carbapenemase. It's clinically resistant to all beta lactams, and you should ask somebody for help. 5 minutes, okay. And here's some vaginal fungal cultures. Again, or yeast infection. There's a whole bunch of different kinds here, but this is an ESBL report. You always want to look where it says positive in really big letters. That means it's something you want to look for. Positive for an ESBL, like, okay, I got it. I understood what you're trying to say there. And just a few other factors I want you to think about when you're looking at different lab results. One of the things that's always recommended is that you want clear and accurate reporting. And I don't know about you, but I can't read that. That was like from a faxed copy of a lab result. And I'm sure you see that all the time when you get labs faxed to you. So like, it's not helpful when you can't tell if that's an S or an R or what is that. Like, that's really, really terrible result. So I would ask the lab or somebody to refax it or send it to you electronically so you actually had an accurate. So that's just something I wanted to point out. And then sometimes we have these panels that are positive for stuff, and like the whole diagnostic stewardship thing that they were talking about earlier. This is what one of those GI panels can look like. And you're like, oh, do they have C. diff or not? Maybe the toxins are positive. Anyway, so this just an example. There also are some bacteria that have intrinsic resistance, so they're naturally resistant to some antibiotics. So Jenna told me her favorite was Pseudomonas and ceftriaxone. So that's the example that I gave. This was a Pseudomonas result that we found. Notice that ceftriaxone is not listed on your antibiotics that it can be susceptible to, because the lab is going to suppress those that they're intrinsically resistant to. They're just naturally resistant to it. There's no point of resulting it. You don't want somebody to treat them with that, so the lab will automatically suppress that. Here's another table that I got from a different hospital that had this published that I thought was really cool, that tells you a bunch of different organisms. And if you guys click on the link there, it'll give you more, but what different organisms are naturally resistant to, so you wouldn't want to treat those infections with those antibiotics. I thought that was a really cool table. And then some bacteria also have predictable susceptibility. So you're not going to see a susceptibility panel. So an example would be group A strep. It tells you, where does it say I have that? Oh, group A strep is an example. Group B strep, it'll say, susceptibilities to beta hemolytic streptococci are not routinely performed due to predictable susceptibility to penicillin. So like, that's where like your provider should know, this is what the first line of treatment is, and you're not going to see a culture result because they don't particularly usually do cultures on that. So here's the different examples of those. This is a chart that I feel is very helpful. That's on page 18 of your workbook that I really like. It kind of tells you by body site what different pathogens are considered normal, or like, you know, like something's normally sterile, what normal flora is for that type of pathogen, and then what something could be if it was like considered a contaminant, or, you know, like that. I think that's a really cool. I have this, I'm going to hang this up for me in my office because I think it's really helpful to know when I'm looking at the lab, like, oh, that might be a contaminant. Maybe we need to recollect the urine culture, something like that. And here's some examples of different results that say something is contaminated. Like one urine culture says, you know, mixed microbial flora indicated. If you can't really tell clinically significant, you need to collect a new specimen. So those kinds of things. So in summary, it's not always easy to do interpret these microbiology results and what they actually mean for you as an infection preventionist. It is important though to clearly understand what your results say, and so you can make the right choices for your patients in your buildings. So the clinical lab is an extremely important partner that I don't know, you guys don't get to interface with that much in long-term care because usually it's like a send out test and you don't get to see it. But if you ever do get a chance to go, you should go. And if you ever have a question on how to interpret a result, you can call me and I will help you. So you guys have our phone numbers. You can email me. You can be like, hey, I've had people send me screenshots. So like, what should I do with this? And I will walk you through it. So just don't feel free, like always feel free to reach out. And these are all of my references. Questions? Did I get done on time? I really tried. Dr. Ashraf stole some of my time, so I went for it because it's lunchtime. And I was like, yes.
There are some super good examples in the work.
Okay,
So
what pages?
Or
I don't know if I did. What pages is it on?
7. And I think if you guys don't have time to like go through them today, these would be awesome, like take home points when you get back to your stewardship committee. The idea of like, how does your facility get these results? Who sees those? Who's accountable for looking at them? Are they going to hit your desk? It's a really important question.
And if they're not, you probably want them to, because there's more to those results than just stewardship. I know we're at a stewardship conference, but you need to be aware of the organisms that are your residents have and how you need to mitigate those. So yeah.
So the same case that we were working on before, there is an example here that 48 hours later, Mrs. Smith antibiotic susceptibility results are returned from the lab to your nursing home to review. And so they're in their vet book on page 7. And so the organism is actually resistant to the Cipro that she's currently receiving. She has received 2 days of treatment so far, and she remains clinically stable without fever or worsening symptoms. And so what are some of your thoughts right now?
Shouldn't have started really about it.
Yeah, we shouldn't have started it. Yeah, that's
Yeah. So what would you do?
Not get the right one.
Bingo. Bingo.
There, she's stable. I hear something.
She's stable. You could just stop. Yeah, is it indicated? Is it needed? Exactly. Yeah.
Antibiotic timeout.
Nice. I like all those hands.
Resource on the ASAP website of kind of the steps to take if this happens. It'll walk you right through that. Just like your team could choose to do an SBAR, you could choose to do that antibiotic timeout tool as an intervention. So we're in the way of people going to lunch. And so are there other questions or comments?
Yes, so I think, yeah, definitely if she's not having any more symptoms are gone, definitely no need for antibiotic now.
Right.
Still continue to have symptoms, but yes, we need to look into why she has symptoms, maybe she needs a different antibiotic. But I think the third question on that worksheet was about, what do you do for, I think, surveillance purposes about this? Like, you know, is this the first time they have seen this, or is it a common occurrence now in the facility to see this kind of resistance pattern? What do you do in those kind of situations? I think that's something that goes back to the previous talk about having a surveillance system, having some time to be able to monitor these organisms and see, if you are seeing a trend towards increasing cases, then definitely you need to take action. And probably Lacey will give you a call anyhow to do some colonization screening testing around this patient in your building, because now we need to know whether other folks in the building are actually exposed to this or not. So those are some of the points to clarify. Thank you.
Awesome. Do you have any tips for lunch, Kate, that we need to? It's next door, so you guys feel free. I think, is it tacos? Is it tacos today? It's taco bar. So come back at 12:30. Thank you, guys. Hey.
Talk to you